a detailed conversation around using mPallCare care to strengthen palliative care in humanitarian contexts. This is a context where the need is high. This is a context where travel is complicated. And this is a context where we need to be frugal and make the best use of every dollar that we have. And this is also a population with complex symptoms and concerns. And this is the overview of our presentation. We are going to talk through the digital health, the situation of digital health interventions in humanitarian contexts. Then we'll discuss the mPAL development and overview. This is the innovation for increasing access to palliative care in humanitarian settings. And then we'll discuss our piloting experience of this intervention. And this was done in Bidibidi refugee settlement in Uganda. And this is one of the biggest settlements in the country. And remember, Uganda hosts the biggest number of refugees in Africa. Uganda is the top Pan-African country, which welcomes everybody who is running away from harm to home. And lastly, we'll talk about the current and future plans. So this is a systematic review about technology for healthcare in humanitarian settings. And what this review does is to summarize whatever we can do using technology to support healthcare in humanitarian settings. What can we do, and what are the potential loopholes or limitations? And then the review also summarizes the opportunities that we can harness, and also it describes some of the risks that we need to take into consideration. For example, if we are to use artificial intelligence, what are the potential risks? So as we think about technology, we should also undertake internal reflection and weigh in on the risks, and therefore think of innovations for mitigating these risks. Next slide. Now we are going to talk about what one needs to think about if you're to innovate or put in place an innovation in the context of mHealth. First of all, what is the existing state of evidence? And over the 10 years that Matthew via University of Leeds and the African Palliative Care, over the 10 years we've been working together, and this is the journey that we have taken. We undertook systematic reviews to see what health workers are using mobile phones for when it comes to delivering palliative care services in Africa. And we mapped what is being done, at what level of service delivery, and what have been the benefits of using the mobile phones in care. And then we also undertook another systematic review, which was about the state of mHealth development and use by palliative care services in sub-Saharan Africa. So as you can see, we are coming in from an informed point of view. We've put together that atlas of whatever is happening in terms of mHealth in Africa. And then we moved on to the second level of thinking about the problems that we have, and then thinking about the solutions that we have, and piloting these solutions to see how they work. For example, we started with an innovation of how we can improve reporting on opioid use for palliative care providers, and generally strengthening pharmaceutical systems for palliative care services. So this app was to help them report better on opioid use and also to do their pharmaceutical reporting in a way that is powered by technology, and therefore they were able to take less time. Instead of blocking a whole 15 days that this is allocated to pharmaceutical reporting and stock taking, they were able to use this application to cut down on the time required for reporting, for stock taking, for identifying stock that was about to expire. And we piloted this application at Hospice Africa, Uganda, and then Gombe Rural Hospital in Uganda. And we noted lots of positive outcomes. And we said, yes, there is an important role that technology can play in improving the way we deliver and manage health services in Uganda. And then another example is the rescue program that was conducted in Nigeria. And this was about the development and evaluation of an electronic platform for pain management education for medical undergraduate students in Nigeria. And still we noted that through the use of technology, it helps more health professionals access the training, and they are able to do it at the convenience of their working stations. And therefore, this cuts down on the time spent in movement, and they are able to concentrate on taking the courses that are going to help them care for patients in a better way. And the third layer is about stakeholder engagement to understand the requirements of the digital approaches. And in stakeholder engagement, we have the policymakers. We need to know what kind of information they want, in what format they need this information, and how frequently. And then we also need to talk to the service providers. What information do they need and in what formats? And at a lower level, if we are also to work with community health workers, still it's important that they are part of the stakeholder engagement. And in partnership with Leeds University, Makerere University Palliative Care Unit, we were able to walk through all these levels of stakeholder engagement, and most of these outputs have been published, and we encourage you to read the content so that you really appreciate the matrix that one has to follow if they are to come up with a mobile application. And for me, I would say that it's important for us to learn from each other as opposed to developing new technologies without looking at what exists already and taking advantage of that platform. Next slide, please. So through that detailed work, we were able to come up with what I would call a theory of change. And in this infographic, we present cross-cutting themes on digital technology as an acceptable and promising approach to improve communication across stakeholders and to enhance the delivery of palliative care. And through this work, we were able to identify attributes of digital technology, and these include availability of mobile phones and tablet devices in the community. And thank God, the Communication Commission surveys being undertaken in Africa are showing an increase in availability of mobile phones and tablet devices in the community in all African countries. And then the second attribute is user-friendliness. The app has to be user-friendly. And then affordability is important. Then if we use the technology, we can avoid travel costs and waiting times at clinics. And then the other important attribute is willingness for use of technology across stakeholder groups. And then the other important attribute is avoidance of data loss. If you bring in an innovation and then you can't mitigate the data loss problem, I think you wouldn't be helping, but instead you might cause a crisis because data cannot be accessed when it is needed. And we notice that when it is digitized, it is less prone to losses as compared to the paper formats. And then there is this other segment on data and information needs, and this cuts across patients and caregivers, health professionals, and policymakers. These segments of the population have different data and information needs. I'll give the example of patients and caregivers. Their data and information needs, for example, are around support during weekends and out of hours. What can I do at night? Who can help me at night? And then access and sharing details and concerns around their condition. If I have a condition, I need to know about the prognosis, the treatment, and what to expect. And those are some of the data and information needs that patients and caregivers have. And then when we come to health professionals, their concerns are around monitoring of patients between consultations, then follow-up and long-term care of patients, and then understanding performance, for example, reach and impact, and then delivery and provision of care, especially in rural settings. And when we come to policymakers, their needs are different. For example, they are concerned about trends and changes, trends and capacity. How is the provision of care changing over time? And then insight into the response and impact of changes, and then new approaches in the provision of services or new approaches in the way we care for patients. And then policymakers are also concerned about increased completeness in the data that they receive, and then training needs across health facilities. Those are some of the questions that policymakers need. And if we are to develop digital technologies that are responsive to their needs, that are providing data to make them better planners, to help them make data-driven decisions, these are the things that we need to think about. And then the digital technology requirements is another thing that we need to think about. For example, the 24-hour access point to a series of trained health professionals, especially during emergencies. For example, we have technology-powered solutions to accessing mental health services in Uganda. You can call a toll-free line and somebody, and you'll get an automated response if you call outside work hours. And then when you call during work hours, you'll have a person to talk to. These are some of the responses. These are some of the requirements or preferences that people and technology users have. And therefore, if we are to think about developing technologies, these are some of the requirements that we should take into consideration. And the other requirement is about curated information, for example, about cancer conditions. I may have a question about breast cancer. Somebody may have a question about cervical cancer. So do we have information that is tailored to the needs of the various patients and caregivers? And then there should be flexibility in when and how to interact and respond. I just gave an example of you being able to speak to somebody. There could be an automated response, and there could be self-help videos or a leaflet that somebody can look at and have their question answered. So briefly, that's what I want to say about technology requirements. And then when it comes, okay, then I'll draw to this important mPAL concept. and purchase contributed to the development of this. We all remember the COVID-19 pandemic, and God forbid, this is something that should never come back again. And we were challenged to look into what technology could do for us to ensure that people get access to care and that people get access to the holistic care that we commonly provide as palliative care professionals. And in this document, there are some briefing notes on how we can use technology to increase access to care, even under difficult circumstances. And this is important for us in Africa because we have emerging and re-emerging pandemics. For example, we have had Ebola over the last couple of months, and still we would need this technology to ensure that care gets to the people, even when we cannot interact with them physically. So this is a very useful resource document. Next slide. So now everything is about person-centered care. And here are some tips on how to develop a person-based approach. If you're to talk about mPAL development or developing mobile applications, you need to take a person-centered approach. And what does this mean? You need to start with planning. What are the key behavioral issues that you need to address? Or what are the needs? Or what challenges must this intervention address? Because if you don't get that right, then the intervention may not solve the problem because the problem is not well defined. And in developing our application, this is the approach that we took. And then once, okay, yes. So this, here we provide some details. The planning involves building on earlier designed research. This is where I said that undertaking systematic reviews helps, and knowing what already exists is important. And then if they are validated outcome measures, it's better to draw on those as opposed to developing your own. And then if there are some self-management resources, it's useful to draw on those resources, avail those resources to patients as opposed to developing your own. And in our practice, this is what we followed. And then we get to the design stage. This is where it is important to engage service providers. And in our case, we engaged the International Rescue Committee. We engaged the United High Commission for Refugees in Uganda. We engaged community volunteers, Ministry of Health Uganda, and the Uganda Cancer Society. And then we put all that feedback together and we developed the first prototype of the platform, and then this was tested. And once this was tested, we moved on to the next step to develop and evaluate the feasibility and acceptability of this platform. And we had a lot to learn from this feasibility testing, and we are drawing on these lessons to take us to the next level. And this is briefly the layout of the mobile application that we are talking about. The first column talks about the application itself. First of all, it can be completed by members of the village health team, or by the patients themselves in the community, or by a member of the family in the community. And the app includes a symptom screening tool. It screens for symptom distress, tuberculosis, and hepatitis B. And these last two, the hepatitis B and tuberculosis, were proposed by the partners in the camps because these are highly prevalent conditions and most of them are usually caught late. So they thought the use of this mobile application could help them identify suspected cases who can then be checked on and tested, and then they are initiated early on treatment to optimize outcomes of care. And then we have outcome measures. And for outcome measures, we are using the palliative outcome scale. And this is a scale that has been developed in Africa and used for over 12 years. So you can see our choice of the outcome measure is based on evidence. And this is completed after 3 days. And then we have information on self-management for some of the symptoms. And this is also accompanied by some videos. And all of this was informed by available literature for self-management on some of the common symptoms in palliative care. Then once this information is completed at patient level, it is transmitted through to a dashboard, which can be accessed by the palliative care team. This is the palliative care provider at Yumbe Referral Hospital. And then also the clinicians who are in charge of seeing patients with palliative care needs within the health facilities in the camps. And when they see this data, this patient level data, they are able to respond and plan their care as needed. And because the care is informed by patient level data, there are lots of intended outcomes. And these include improved preparedness and resource targeting for managing of palliative care patients and the most prevalent conditions. There is improved access to and use of patient-level routine data, and then improved responsiveness because data is received in real time and therefore better quality of care. And then we have improved symptom management. And whenever this data comes through, the clinician is required to document the action or decision that was taken. And the decisions range from contacting the patient, making a referral, or sending through the medication that may be required. Matthew, do you want to take over from there?
I can do. Do you want to just give a quick overview of the context of Bidi Bidi, the refugee settlement where we conducted the work, and I'll talk through the feasibility, acceptability testing, if that's okay.
Yes, this is Bidi Bidi, and I said it is the largest refugee camp in Uganda, and it is located in northern Uganda, closer to the border of Uganda and South Sudan. And we have about 23 health facilities which are located within the camp. And within those 23 health facilities, we have some clinicians who have been trained in palliative care, and they know the patients with the palliative care needs. And we work with the palliative care team, works with them to keep an eye on what is happening to them and what type of care do they need at what point. So their first point of contact is the health facility within the camp. And if there is any need for palliative care, they are usually referred to Yumbe Referral Hospital, where we have a palliative care nurse who coordinates the palliative care services. And if they need to be referred for further care, the nearest point is Arua Regional Referral Hospital, where we have a hospice, and then we have hospital-level palliative care services. And it is a huge and massive place, and the settlements are scattered. Therefore, movement is a little bit complicated, and the use of technology is very helpful because the nurse will know who needs what urgently and where are they and then they will coordinate with the members of the village health team and the healthcare providers within the camp to be able to respond in a timely manner. And this is critical because you need to plan. Otherwise, you may spend the whole day moving and you'll be able to pay attention to just 1 or 2 patients if you don't plan well.
Let me speak up from here, Eve. I can talk through the feasibility, acceptability study. So Eve's given an overview of the concept of mPallCare and the general idea. So in kind of theory, great idea, increased reach to services. But I think after we'd done the initial development, we were really keen to understand actually how feasible is this in practice? Is this an acceptable approach to patients, to the village health team members, to the clinical team? So we've been developing the platform over a couple of years, and the work I'll talk about here, we actually carried out the feasibility acceptability testing between around 2022 and 2023. So we've recently completed the analysis, and that's what I'll present here. mPallCare has evolved and developed in that time, and at the end I will just kind of talk about where we're up to with things and kind of plans for next steps. But in terms of study methodology, we began first with training for the VHT, the Village Health Team members, who would be supporting data collection with patients in the settlement. So in total, we trained 20 Village Health Team members, and they were provided with training manuals that supported navigation and use of the mPallCare mobile app. And they also received in-person training as well. There was a session that was hosted and led by APCA. So an IT specialist from APCA provided an interactive demonstration, and then VHTs were able to practice entering patient outcome and symptom reports using the app, and also the process of accessing the self-management symptom guidance too. It's worth noting as well that the training was also attended. Even mentioned the co-design work that had happened. We also had representatives from the regional referral hospital, so Yumbe District Hospital, the District Health Office, and also Ministry of Health of Uganda and UNHCR also attended that training, just to help raise awareness of the project and ensure there was sort of commitment to the delivery of the project as well. And then we asked the care team in the settlement to identify and approach potential participants. And you can see here we were seeking to approach around 30 to 35 adults living with advanced cancer for this initial pilot testing. And we felt at this point, keeping the focus on a specific disease category would be useful just to provide that initial focus for the testing. But the platform is designed to capture symptom outcome data across, sort of any patient groups accessing palliative care. And we also made sure that the list of participants included both participants from the host community in Uganda and refugee populations. And this just aligns with a much broader kind of strategic framework that's been developed by there's the UN country teams in Uganda and also Ministry of Health. And these are much kind of wider efforts for these organisations to support integration of both host and refugee communities and promote sort of peaceful coexistence. So we made sure that we replicated that in our recruitment. So in terms of the procedure for the pilot study, we provided mobile tablets to support data collection for the village health team members, and the tablets were retained in the health facility when they weren't in use. That was just to ensure they were securely stored, that they could be charged and they'd be ready to use. And then at the start of the study, before a patient's symptom and outcome data started to be collected by VHT, patients were asked to complete a baseline demographic questionnaire. Village health team members then completed the first set of outcome and symptom reports for the patient and could review and talk through the symptom self-management guidance with them. The village health team members then subsequently visited patients every 3 days to complete and submit a palliative outcome report, and then once weekly to complete the symptom screening report. And these visits took place over the period of the 6-week period of the study. At the end of the 6 weeks, some of the patient participants, we had a subsample that took part in interviews just to understand their experience of mPallCare, and we also had a subsample of VHTs and clinical staff who were interviewed by Eve Namisango, who's a very experienced researcher at the palliative care unit at Malaga Hospital in Kampala. So then for data analysis, we had both the data from the mPallCare platform, so the data that had been submitted, and we had the transcripts from the interviews. At the bottom there, I've just defined, before we did the analysis of the mPallCare data, we defined a kind of criterion for deeming mPallCare to be feasible. So we kind of decided we wanted to see over around 60% of all scheduled reports being completed. So just to talk about the study population, in total 32 participants took part. The majority of these were female. Most participants reported being Christian, there's about 60%, and a majority were married, so about 53%. The age of patient participants ranged from 18 through to 77. The average age was about 48.5. Primary caregiver was the most often a spouse, but children and parents were also commonly reported. Interestingly, the majority of patient participants didn't own access to their own mobile phone, although a lot of patients did have access through caregivers and through communities as well. So it's extra helpful that we had the VHT supporting data collection. So all 32 patient participants completed symptom and outcome reports, and the graph shows on the right-hand side shows the frequencies of responses across participants throughout that 6-week study period. In the first week, you can see was the highest frequency. So most participants, there were really high levels of engagement with the app. But as the study progressed, you can see overall weekly responses did reduce. For symptom screening reports, there could have been up to 192. So for 32 participants, there were 6 time points to do the weekly screening over the 6-week period. Overall, we had 163 reports submitted. So that's about 85% of all reports. From a possible 448 outcome reports, so this was the 14, there were kind of 14 for each participant across the 6 weeks. We had 266 completed, so that's about 60%. And there's quite a range across participants. Some only completed 3, up to kind of completing 13 for some participants. So overall, kind of 429 of 640 reports were submitted, so that's 67%. So we just felt that that did meet our threshold for sort of deeming this type of approach as being feasible. And then just to quickly look at some of the data in more detail, this shows the individual mean scores for each item. And this is just looking at the data for the APCA palliative outcome scale reported across the study period. So for example, in the first box on the left, they're the scores for the item, please rate your pain during the last 3 days. And then over on the right-hand side, the furthest right, you can see there's an item around have patients felt they've received enough help and advice to plan for the future. That's again another item. And each item can be scored between 0 and 5 on that kind of 6-point Likert scale. So for example, for pain, those familiar with the APCA POS will know these. But for example, with pain, 0 would mean indicate no pain at all. 5 would indicate overwhelming, kind of worst pain imaginable. And this is just showing those average, the data we captured during the study. So the higher the rating, the more problematic symptoms were. So we can see shortness of breath, vomiting, soreness, or dry mouth and drowsiness are all up in that sort of 4 to 5 average brackets, are really problematic. And most other items had overall means of sort of 3 to 4. Slightly lower down, we're feeling worried and a sense of receiving enough information. So still high burden, but they were slightly lower rated. And we're still really kind of exploring how to make best use of the data at service delivery level, but also more broadly at the kind of population level. But we wanted to have an exploratory look at how data changed throughout the study period. So these graphs plot the trends in reporting across 5 of the items from the APCA POS. And you can see here we have the sort of key items around feelings, which is where the participants can share concerns with family and friends. There's concerns, so whether participants felt worried. There's items then around life feeling worthwhile, being at peace, and receiving enough advice. And each grey line, these are a bit of a mess, and I will share a PDF of the slides afterwards for if people would like to have a closer look. Each grey kind of line shows an individual patient's data plotted. And then what we have running through the middle in blue is the kind of overall average scoring across that period of time. So when we're interpreting these graphs, a slight increase would suggest an improvement or positive change across those items. So you can see that happening for 4 of the items. There is a slight, although for peace it's very, very slight. The only item where there's a slight reduction was for concerns, so sort of feeling worried about their illness, which would suggest those scores reduced over the 6-week period. In a kind of negative way. So generally at the sort of study population level, over that 6-week period, we've seen some improvements, but we've yet to sort of explore these data a bit further and really understand how we can get most value from them. And then I'll just quickly go through the sort of interview data when we're looking at acceptability. So this is the patient interview data. There were 3 themes from a subsample of 10 patients. Theme 1 was about ease of use, perception of usefulness, and we found that some participants were highlighting initial difficulties in understanding how the app worked, and that included around the sort of content and how data was being submitted by the VHT, the village health team members, but this became clear with support from the VHTs and over time as more reports were being completed. Participants also reported that self-management resources that were included in the app were helpful around symptom self-management, but could be enhanced through a range of different ways. So we had suggestions including more visual aids, such as pictures, as well as improving the format and presentations. So increasing font size, using more accessible forms, such as pictures, videos, audio-based content, for example. For theme 2, about understanding of the questions and perception of the data use, the patient participants generally agreed that questions were easy to understand, context appropriate, and addressing their sort of most troubling symptoms, such as pain, as well as what participants perceived as kind of being often overlooked mental health concerns were being picked up in some of the screening, some of the tools. However, while the symptom and outcome items were easy to understand, the process of providing the numeric ratings and responding to some of those numeric rating scales was quite unfamiliar at first, and was quite difficult for some of the participants. I think over time, patient participants also reported becoming quite confident that the data that was being submitted via the mobile app was being accessed and used by clinical teams. And that was particularly when discussing symptom management with the clinical teams. Some of the information that had been entered had been picked up and discussed, so that sort of reinforced that kind of validation that the data was being used and reviewed. Just the third theme about the impact of the intervention. Some of the participants reported the intervention made respondents feel closer and actually more connected to the healthcare teams, and that made them feel more comfortable sharing symptoms and concerns. I'll just quickly go through the clinical team VHT interviews. Again, three sort of themes there. The first was around the perceived impact. The VHTs broadly agreed the intervention improved patient care, having that real-time or near real-time access to symptom data helped them identify and respond to issues earlier. But a few clinicians did report feeling more removed from the patient, sort of relying on second-hand reports from VHTs, and that perhaps highlights the importance of balancing remote data collection with direct patient interaction. So there are a few things, again, through the implementation, we've received a lot of useful information about how we can improve the implementation process. And again, there was some useful findings around data robustness and reporting as well that I'm just mindful of time. We can sort of pick up on, maybe in the discussion. I just wanted to quickly say where we're kind of up to with current activities. So we're happy from the preliminary testing. mPallCare seems feasible. It was broadly acceptable when it was pilot tested. But we're also mindful of the experiences shared and kind of really using that feedback to improve the platform. And over the last 12 to 18 months, we've been trying to do that. So a big change has been the IT company that we're using now is MRT IT. That's a leading IT technology company based in Uganda. They've got a really strong track record of working with the Uganda Ministry of Health and also APCA as well. And just to kind of say some of the changes we've made over the last the last year, we've rebuilt the platform to include multiple additional local languages. At the time of the testing, it was only available in 4 languages. Since we've been doing a lot of work in northwest Uganda, we now include content of all the reports in Madi, Bari, Lingala, also in Chichiwa, because we've got some ongoing testing in Malawi. And what we've made sure is any additional languages can be added to the platform really easily. So hopefully that'll accommodate sort of further rollout across multiple countries and settings. We've also adapted the scheduling of symptom and outcome reports. During the description of what we did, some people might have thought it was a crazy idea to have the kind of APCA pause running every 3 days and the symptom screening every 7. And then when that gets out of sync, it's just kind of creating a lot of challenges in terms of knowing when to visit patients for the VHT. So we've synchronized just to once weekly reporting now. Some of the content's changed as well. We've enhanced the self-management resources to include video content now, particularly for activities like low intensity physical activity exercises. And we're really enhancing the dashboard for policymakers, for the clinical teams as well. We do still have lots of questions. How can we best use dashboard analytics to support clinical decision making? Lots of things, and we'd really encourage further collaboration and for people to be involved in this process as we kind of trying to develop the platform. So I'd really welcome collaboration around that. This is just very briefly the kind of overall vision we have on the left. We have patients and carers providing information. We have health services looking at the data, reviewing it. Over on the right-hand side, we also have this real opportunity once we start collecting data on a much larger scale, thinking about evidence-informed policy making, how we can understand provision of care and maybe changes in outcomes, the most problematic symptoms across perhaps country or regional level, and then also thinking about how the aggregated data can inform research and what we know about problematic symptoms within different populations. So this is kind of where we're moving towards. And thinking, and once you start getting those larger data sets, it provides opportunities for machine learning. Lots of big data analytics. We won't jump the gun and start getting too excited. So we're starting with the feasibility acceptability. So we'll build it up, but this is kind of our overall plan and vision for mPallCare.
Thanks, Matthew. There's so much in those talks. Thank you very much, Eve and Matthew. We have kind of slightly run out of time for questions. So what I'm going to do is I'm going to save your questions till tomorrow, if that's okay with you. And I'm just going to take Andrew's just now. We'll just maybe take that one question. But can I say to all of you, go and read this material. And we've also done some feasibility work on using a different kind of technology, well, similar mHealth for research. So there's so much expertise here, and it's brilliant to see the development of this new platform going forward. And I presume we've got 18 countries worth of people on this call. I presume Matthew and Eve, people who want to collaborate and are interested can pass that through us, including through the PalChase Research Group, because both Matthew and Eve are on that. But can I just ask, there's just couple of quick questions there. One was around this can be used in health facilities, which I think Andrew was asking from South Sudan. So I think you've answered that already because you're using it in the community and in the facility. Is that correct? Just check that one. From Eve or from Matthew?
So what was my, sorry.
There was a question. Sorry, we've just run out of time for questions. So I was wondering if you wanted to answer some of them in the chat itself. One of them from South Sudan, he asked whether or not this can be used in the health facility as well as in the community. I think you've said it can be used in both, just double checking.
Yeah, it can be used in both.
Fine. Yeah, so Andrew in South Sudan is probably interested in that. And then there's just a couple of questions around confidentiality and also sustainability in terms of the technology and the airtime. They came from Rick. Any comments on that from either of you?
Can I comment on that confidentiality?
Please do, Eve, yes.
Yes, so confidentiality is ensured because we have segmented the different users, and you can only access the data that you need to make your informed decisions. For example, a policymaker would never get to see patient-level data. What's my name? Where do I stay? What am I suffering from? Because they don't need that. They are not providing care to me. This will only be accessed by my healthcare provider. So we've done that segmentation, and we've tried to align everything with the local data protection guidelines.
And just to come back on the sustainability, Moira, I think like all this work, as Rick rightly points out, the funding is a big challenge, and this has come through a patchwork of funding internal from University of Leeds, externally through certain funders. I think what we're trying to do is get to the point of proof of concept, which we have done, I think, and now we are starting to engage with ministries of health. We know this approach is feasible, so can it be taken on? So, for example, we have pilot work going on in Malawi at the moment. The Digital Health Division is really keen to adopt this type of approach and absorb it within their own systems. So in Malawi, that would be the perfect outcome, and then that kind of becomes, routine care or routine practice. Hopefully, what that looks like. This is kind of a landscape we're trying to navigate at the moment, but sustainability is certainly on our minds. We're not handing out tablets anymore, so this is down to the healthcare teams to be using their own devices, which, you know, we designed the platform to be possible for them to do. Let's see how that's taken up and explore the sort of new challenges that will come with that, no doubt.
I think that's a brilliant way for us to end there. And I think you're picking up that, you know, transport's also expensive, and, you know, going and trying to find a health practitioner is also expensive. And maybe there's the proof of concept and feasibility may then be taken up and replicated. And I see that Nala is already talking about work that she's doing and I'm doing with her in Sudan and Gaza. So lots of potential ways in which this can extend. I am going to pull the questions to a halt there, but if you would like more questions, join tomorrow, because Matthew and Eve will both be with us and we'll have a little bit more time for questions. But can I say a huge thank you, exciting work, and the way in which you're really proving the concept is going to be hugely useful to so many of us. So thank you very much, both of you, and look forward to tomorrow. We are going to move